Good afternoon, everyone. So today I'll be discussing an endometrioma, presence of an endometrioma before IVF. To treat, that means to surgically address it or not to start. So let's discuss what is the evidence-based approach to this. So now, whenever we are discussing on the forum, it's literature based, plus we add a practical experience. The challenge here is that, as rightly said, there is not much which is understood about these disease, and always there's an enigma, there is interest, and there is controversy. So this particular point will be discussed by my co-speaker. But what leads to impaired fertility in endometriosis? Basically, the alteration of an immunologic milieu in peritoneal cavity which creates a hostile environment for the gamete interaction early embryo development. In pelvis, it's called distortion of the anatomy, altered peritoneal fluid, migration of inhibitory factors, leading to hindered sperm capacitation and hampered two-side sperm impact. Now, what happens to the ovary? There might be cysts, that means endometriomas, which cause space-occupying effects, local reactions, and growth. So, what leads to is huge amount of functional ovarian tissue. Now, regarding addressing an endometrioma, there is always a tussle between the endoscopist and infertility specialist. They are more in favor of putting in a scope, doing all the clearance, and we want untouched ovaries. We don't want anybody to touch ovaries before we are taking our patient for an infertility treatment. Now, there is insufficient data to clarify whether the endometriosis-related damage to ovarian responsiveness precedes or follows the surgery. Why the decisions are difficult? Because many clinical decision points have not been evaluated in randomized controlled trials. Now, all these guidelines I've tried to include when I'll be deliberating this topic. Now, just a common clinical scenario: a 32-year-old female married for 6 years with a history of operative laparoscopy for bilateral endometriosis. An ultrasound shows normal uterus, a bulky right ovary with a left ovary showing an endometrioma of 4.5 or 4 centimeters. FSG shows palliative corneal block, so we have taken a decision by 9 years. Now the question arises, endometriomas are IVF. So generally we say whenever in doubt, cut it out. So does the endometrioma impair the results of IVF? And do you want to surgically treat it? Now, if we go to the pathology, how do endometriomas happen? They are basically an invagination of ovarian cortex. So a healthy ovarian tissue is always sticking to the cyst wall. And there is evidence to prove that whenever cystectomy is done, there is a resection of the healthy ovarian cortex. That arises two concerns. That means hampering of ovarian reserve. Secondly, anyways, this is a disease which has recurrence and it might just come back again. So what are the pros and what are the cons of a surgical treatment of endometrioma before an IVF? So what favors surgery? There is a risk of pelvic abscess from a ruptured endometrioma, risk of a malignancy because there is no histopathology without doing a surgery, difficulty in oocyte retrieval, and if while doing a retrieval, if there is an accidental puncture of endometrioma, they can do an ovarian abscess, and theoretical risk of endometriosis progression. What favors not doing a surgery? Surgical related damage to the ovary. Surgery, they can be minor and complications. The additional cost, lack of evidence that surgery might be. So now it's in 2017.
Nymphea, your voice is not clear.
Is it better now? Hello?
Slides are okay. Voice बीच में break हो रही थी. Slides are okay. We can see the slides full screen कर दीजिए उसको.
It will be better if she uses mic. Yeah. If she uses earphone, it will be clearer, I think.
Actually, there is a lot of noise around. That's why I specifically use it, because otherwise there will be a lot of disturbance.
It's okay. We can read the slides.
NICE in 2017 said that whenever you are thinking about a surgery, discuss the benefits and risks with the concerned patient who has deep endometriosis. What points are to be discussed? Whether laparoscopic surgery alter the chance of future pregnancy, the possible impact on ovarian reserve, possible impact of fertility if there is additional complications because of the surgery. What are the alternatives to surgery and other fertility factors? So does surgery really help? Let's see what the evidence says. So a recent systematic review and meta-analysis of 2018, which has included 11 eligible studies, showed that there were no significant differences in pregnancy rates, clinical pregnancy rates, and live birth rates between women who underwent surgery and those who did not. It is pertinent for clinicians to assess the risks of surgical intervention on an ovarian reserve prior to initiating therapy. This is another review article from 2019, which said that there is no clear evidence that supports the use of a surgical intervention before IVF. Now, it also says that when pain is severe or when any malignancy is suspected, cystectomy might be justified. When the size of endometrioma is very large, surgery is required prior to IVF to facilitate access to follicles during a retrieval. Control ovarian stimulation. There are other studies a little older. This is one from 2015, which says that women with and without endometriosis have comparable ART outcomes in terms of live birth rate, whereas those with severe endometriosis have inferior outcomes. But there is no evidence to recommend surgery routinely before an ART. And as I said, we discussed the theoretical risk of endometriosis progression. So this was an article from 2013. This said there is no evidence to suggest that ovarian stimulation associated with IVF is a progression of endometriosis. So the 2022, which addressed this particular question, that are surgical therapies effective as an adjunct prior to medically assisted reproduction? Now clearly says that clinicians are not recommended to routinely perform a surgery prior to ART, even in endometriosis stage 1 and 2. Clinicians are not recommended to routinely perform surgery for endometrioma prior to ART to improve live birth rate, as current evidence has no benefit and has a negative impact on ovarian reserve. Surgery for endometrioma prior to ART can be considered to improve endometriosis-associated pain or accessibility of follicles. The decision to offer surgical excision of deep endometriosis should be guided mainly by pain symptoms and patient preferences, as its effectiveness and reproductive outcome is uncertain. Now, the AS7 2012 says that asymptomatic endometrioma who are planning to undergo IVF, there is insufficient evidence to suggest removal of endometrioma. Now, if the endometrioma is large, there might be situations where you consider putting on a scope, where you are in doubt and you need to confirm the diagnosis histologically to improve access to follicles and probably also possibly improve the ovarian response. Surgery will help in certain scenarios where there is severe dysmenorrhea or deep pelvic pain in a patient of infertility who wants to address both the issues. Presence of hydrosalpingo, you have to anyways want to put in a scope to disconnect the hydrosalpingo, you might consider a surgery. And large endometrioma where there is a doubt about the nature. But before surgery, what should you need to consider? That see whether the patient has had previous intervention. What is their existing ovarian reserve? Is it good or it is already damaged? Symptomatology of the patient, bilaterality of the disease. So if it's a monolateral disease, you will still be, consider that at least one ovary is good. And if there are certain symptomatology which is pointing you to put in a scope for a single-sided endometrioma. In a bilateral disease, of course, you are going to definitely do a further damage. Sonographic features of malignancy and what is the growth. If it is a rapidly growing endometrioma, then also you might need to do a histology. If at all the surgery is being done, always prefer excision over ablation. Why? Because it helps in improving pregnancy rates, improving dysmenorrhea and deep dysmenorrhea, avoids recurrence, and also allows a histopathological examination. That is very important if you are doing a surgery. Now, extremely important here is to ensure that whoever is doing a surgery, a completion surgery must be done. You should not just go in, do a diagnostic copy, or just draining the endometrioma and just leaving it. Taking a qualified person with you always to be done by a person who is experienced in dealing with such stage 4 endometriosis. So if at all you have decided to do a surgery, as you said, do no further harm. Help the patient. So it's an example that this particular scenario is an example where more treatments are there for a disease, more likely than none is ideal. So what do we understand? So the chances of conception is not the only factor that a physician should consider before deciding whether or not the patient should undergo a surgical treatment. Risks of both conservative and surgical treatment should be kept in mind. A study suggests that proceed directly for an IVF, avoid insults to the existing ovarian reserve, reduce time to pregnancy. Now, in the present scenario, whatever treatment we are doing for patients of infertility, time to pregnancy is a very, very important factor. So we don't have to prolong the conservative treatment. We have to give a pregnancy as fast as possible. Besides that, avoid further surgical complications. We know that in a patient who has grade for endometriosis, where all the surrounding organs, we might find a lot of additions. A surgery might lead to other complications and definitely reduce the cost. We should pursue a comprehensive and personalized approach. In any medical therapy, there is nothing in black and white. Of course, a patient might come with a different clinical scenario. Every patient will have a different symptomatology. So a personalized approach in decision making is very important. And the points to be considered are the age of the patient, the symptoms, number of interventions, her reserve, and possibility of a malignancy. Now, there is insufficient evidence to indicate that resection prior to IVF improves outcomes, and surgical management, if done, should include resection or ablation rather than drainage and resection as preferred. If you cut or not, decision is arbitrary. Keep in mind the symptoms. Some studies do give a dimension of more than 4 centimeters, but diameter threshold is not the only thing. Location of the endometrioma is important and the accessibility of the ovary. Sometimes even small multiple cysts, which is hiding the follicles, you might consider removal. Thank you very much.
Thank you, Dr. Nymphea. So I think we can go for Dr. Jyoti's talk right now, and then we can have the expert comments because the topic is so much overlapping.
Correct.
So now I invite Dr. Jyoti.